Good afternoon. My name is Nisa Shafi, and I'm the Associate Policy Director at the Alliance of Community Health Plans. I use she, her pronouns.
I'm Megan Knaus, Clinical Innovations Program Manager at the Alliance of Community Health Plans. I also use she, her pronouns. We'd like to thank 2020 Mom for this opportunity to present a maternal health resource that we developed as part of our work on the Raising the Bar grant, which was funded by the Robert Wood Johnson Foundation. Next slide.
ACHP represents the nation's top performing nonprofit health companies to improve affordability and outcomes in the healthcare system. ACHP member companies serve tens of millions in 37 states and DC and collaborate with providers on high quality coverage and care. Next slide. Our clinical innovation, market competitiveness, and data analytics and advocacy teams work together to amplify data-informed and evidence-based policy priorities for our members. Next slide.
For the past 2.5 years, ACHP worked on a grant called Raising the Bar, Healthcare's Transforming Role. Funded by the Robert Wood Johnson Foundation, Raising the Bar has two parts. Part one developed a framework of principles identifying the ways the healthcare sector can achieve optimal well-being for all the communities it serves. And part two translated these principles into practical guidance with a keen focus on maternal health. ACHP worked on part two specifically as partners to the National Partnership for Women and Families. ACHP's maternal health measure set is a tool that health plans can use to support evaluation and improvement of key components of quality maternal health care. We aim for the measure set to help health plans monitor current performance and identify opportunities for improvement. Next slide. One of the first steps of our work on Raising the Bar was to conduct an environmental scan of ACHP member companies' maternal health work. This environmental scan revealed that ACHP member companies need effective, comprehensive methods for understanding the quality of the maternal health they provide among their covered populations and to better identify disparities in maternal health care. Next slide.
To create the measure set, we formed a maternal health task force, which was composed of clinical and policy leaders across ACHP member companies. We set out to create a tool consisting of both existing and conceptual measures to supplement gaps in current quality measures. During our first meeting, we asked task force members what measures they currently use and what they would like to incorporate. We then combined these measures as well as those from other sources into one centralized spreadsheet. We held monthly maternal health task force meetings to refine the measure set. We also met with external stakeholders such as 2020 Mom, which is serendipitous that we're here today, NCQA, Healthy Women, and the National Partnership for Women and Families, and received feedback from ACHP's clinical, data analytics, and federal affairs teams. Multiple stakeholders noted that while our measure set was comprehensive, fewer measures would be better. We started out with 47 measures, and now the current iteration has 18. Next slide. Next slide again, please. Thank you. Before we start our walkthrough of the measure set, we'd like to explain how it's laid out. Column headings include measure name, National Quality Form endorsement number, measure description, measure status. This indicates whether a measure already exists or is a conceptual measure, measure steward, level of analysis, measure type, and health plan action 1 and 2. The measure category is included in the header of each subsequent slide. In addition to existing measures, we decided to include conceptual measures to represent metrics that stakeholders would like to track, but that measures do not currently exist for. The conceptual measures have a gray background. The measure set is organized into 7 categories: prenatal, labor and birth, postpartum, perinatal, social needs, mental health and substance use disorder, and maternal morbidity. We note in our measure set toolkit that we intended for each measure, wherever possible, to be stratified by race, ethnicity, and socioeconomic status. Individual measures, I'm going to go by each measure category that we discussed earlier. The first measure that you see is the category is prenatal. And the first measure in this category is timeliness of prenatal care. This is an existing measure. This includes the percentage of deliveries in which women had a prenatal care visit in their first trimester on or before the enrollment start date or within 42 days of enrollment in the organization. Health Plan Action 1 is to have internal monitoring and improvement. Health Plan Action 2 is to include the measure in provider and vendor contract negotiations and pay for performance programs. The next measure in this category is prenatal immunization status. This is an existing measure. This includes the percentage of deliveries in the measurement period in which women received influenza and tetanus, diphtheria toxoids, and acellular pertussis or Tdap vaccinations. In the future, we would like to see this measure include the tracking of the COVID-19 vaccine. Health Plan Action 1 is internal monitoring and improvement. Next slide, please. The next measure is gestational diabetes. And as I noted earlier, this is a measure concept this is why it's blocked out in gray. This includes the percentage of pregnant members screened for gestational diabetes according to clinical guidelines. For example, 24 weeks or later for asymptomatic pregnant people, and this is according to the United States Preventive Services Task Force. Health Plan Action 1 is internal monitoring and improvement. Health Plan Action 2 is to include the measure in provider and vendor contract negotiations and pay for performance programs. And the final measure in this category is teeth cleaned during pregnancy. This is an existing measure. And this, of course, is the percentage of pregnant members who had their teeth cleaned during pregnancy. Health Plan Action 1 is to convene or participate in multi-stakeholder efforts to address. And Health Plan Action 2 is internal monitoring and improvement. Next slide, please.
Next measure category is labor and birth. The first measure in this category is PCO2, cesarean birth, which is an existing measure. And this is a nulliparous woman with a term singleton baby in a vertex position delivered by cesarean birth. The health plan action here is to include the measure in provider and vendor contract negotiations and pay for performance programs. The next measure in this category is percentage of preterm births. This is also an existing measure. And this is described as the percentage of births at less than 37 weeks gestation. The first health plan action is internal monitoring and improvement, and the second health plan action is to convene or participate in multi-stakeholder efforts to address. Next, we have PCO1, elective delivery or early induction without medical indication at less than 39 weeks. This is also an existing measure. And this is the percentage of patients, regardless of age, who gave birth during a 12-month period, who delivered a singleton at less than 39 weeks of gestation completed, who had elective deliveries or early inductions without medical indication. And the health plan action here is to include the measure in provider and vendor contract negotiations and pay for performance programs. And the final measure in this category is PCO5, exclusive breast milk feeding, which is also an existing measure. And this is exclusive breast milk feeding during the newborn's entire hospitalization. The first health plan action is to include this measure in provider and vendor contract negotiations and pay for performance programs. And the second health plan action is internal monitoring and improvement. Next slide. So this next measure category is postpartum, and it contains just one measure, which is postpartum follow-up and care coordination, which is an existing measure. And this is the percentage of patients, regardless of age, who gave birth during a 12-month period, who were seen for postpartum care within 8 weeks of giving birth, who received a breastfeeding evaluation and education, postpartum depression screening, postpartum glucose screening for gestational diabetes patients, and family and contraceptive planning. And the health plan action 1 is to include the measure in provider and vendor contract negotiations and pay for performance programs. And the second health plan action is internal monitoring and improvement. Next slide, please.
The next measure category is perinatal, and the first measure in this category is representative OB workforce, and this is according to race. This is a measure concept, and this involves the race and ethnicity breakdown of the health plan's maternity population compared with the race and ethnicity breakdown of the maternity care clinical providers and staff. Health Plan Action 1 is internal monitoring and improvements, and Health Plan Action 2 is to convene or participate in multi-stakeholder efforts to address. And the final measure in this category is representative OB workforce, according to language, and this is a measure concept as well. And this includes the language breakdown of the health plan's maternity population compared with the language breakdown of the maternity care clinical providers and staff. Health Plan Action 1 is internal monitoring and improvement. Health Plan Action 2 is to convene or participate in multi-stakeholder efforts to address. Next slide, please. And the next measure category is social needs. And the one and only measure in this category is social needs screening and intervention, or SNS-E. This is an existing measure, and this includes the percentage of members who were screened using pre-specified instruments at least once during their measurement period for unmet food, housing, and transportation needs, and who received a corresponding intervention if they screened positive. Health Plan Action 1 is internal monitoring and improvement. Health Plan Action 2 is to include the measure in provider and vendor contract negotiations and pay for performance programs. Next slide, please.
Next measure category is mental health and substance use disorder in pregnant and postpartum populations. And the first measure in this category is prenatal anxiety-related screening and follow-up. This is a measure concept. And this is the percentage of members screened for clinical anxiety while pregnant using a standardized instrument, and if screened positive, received follow-up care within 30 days of a positive anxiety screen finding. The health plan action here is internal monitoring and improvement. Next, we have postpartum anxiety-related screening and follow-up, which is also a measure concept. This is the percentage of members screened for clinical anxiety during the postpartum period using a standardized instrument, and if screened positive, receive follow-up care within 30 days of a positive anxiety screen finding. The health plan action is internal monitoring and improvement. And the next measure in this category is prenatal depression screening and follow-up. This is an existing measure. This is the percentage of deliveries in which members were screened for clinical depression while pregnant, and if screened positive, received follow-up care within 30 days of a positive depression screen finding. The first health plan action here is internal monitoring and improvement, and the second health plan action is to include the measure in provider and vendor contract negotiations and pay for performance programs. Next slide, please. The next measure is postpartum depression screening and follow-up, which is also an existing measure. This is the percentage of deliveries in which members were screened for clinical depression during the postpartum period, and if screened positive, received follow-up care within 30 days of a positive depression screen finding. The first health plan action is internal monitoring and improvement, and the second health plan action is to include the measure in provider and vendor contract negotiations and pay for performance programs. And the final measure in this category is substance use screening and follow-up, which is a modified version of an existing measure. And this is the percentage of members 18 years or older who were screened for substance use disorder using a standardized tool, and if screened positive, received appropriate care within 2 months. This measure is a modified version of NCQA's unhealthy alcohol use screening and follow-up measure. The health plan action 1 is internal monitoring and improvement, and the second health plan action is to include the measure in provider and vendor contract negotiations and pay for performance programs. Next slide, please. And our last measure category is maternal morbidity, and there is only one measure in this category, which is PCO7, severe obstetric complications. And this is described as patients with severe obstetric complications which occur during the inpatient delivery hospitalization. The health plan action here is internal monitoring and improvement. You may have noticed that our measure set does not include any patient experience measures. Measuring patients' experience of care during the perinatal period is essential for improving and eliminating equities in maternal health outcomes. Birthplace Labs has done critical work on measuring a specific aspect of patient experience, which is respectful care. We include a link to Birthplace Labs plug-and-play tools, such as the Mother's Autonomy and Decision-Making Scale, in our accompanying measure set toolkit, which was just yesterday released as part of the materials accompanying the Raising the Bar project and report. Birthplace Labs also maintains a respectful care measurement registry, where health plans can select from among 210 validated items and indicators across numerous domains and construct their own tools based on their priorities. Next slide, please.
Thank you so much for joining us for that walkthrough. For next steps, we're incredibly eager to share the tool with ACHP member companies to bolster their maternal health work. We are also excited to announce that this resource will be released publicly alongside other Raising the Bar grant materials. Next slide, please. And thank you again. Megan and I really appreciate the opportunity to present today. We are happy to take your questions during the Q&A period.
All right, well, thank you so much for letting us join you today for our presentation. My name is Kim Barris. I'm the Director of Clinical and Outcomes Management for Select Health, and we're joining to share a little bit about our program, how our program came to be, what we've learned from our program, and where we plan to go from here. Next slide. Oh, actually, first, Kelly, would you mind jumping in and introducing yourself? Sorry.
Sure. No problem. My name is Kelly Burnham, and I am the manager for the Quality Provider Program that we are going to be talking to you about today.
Perfect. Thank you, Kelly. Will you go ahead and next slide? All right, so for our program history, it begins in 2017. Our program bore out of maybe a little bit different pathway than what we would think from the presentation before us and the work that has happened with ACHP. We had a group reviewing our medical trends and had identified a particularly disturbing rate within our population, and that was the rate of our neonatal abstinence syndrome babies. So that was the initiation of our program in 2017. We took 2017 and 2018 to really design the program, perform our research, identify the resources we may have available, and we piloted with 2 practices for that initial program in 2019. Our initial program included only the substance use screening measure. That was our primary focus for the entire first year because we wanted to make sure that we were setting up processes for that measure, setting up communication pathways, and really giving that the focus that it needed before we expanded beyond that metric. And from 2020 to 2022, we continue our program expansion and our metric evolution, meaning we have added more components to that program. Next slide. We wanted to share the challenges and opportunities that we had within our program. The first challenge is screening discomfort. This was a challenge we weren't expecting. When we went out and started meeting with our practices initially, we had some really strong pushback from providers who were incredibly uncomfortable asking these questions about screening for substance use during pregnancy. We heard things like, we didn't get this in our program. We don't typically work with that kind of a population. We don't even know what the resources are to help get them connected. And so our opportunity here, we had actually identified, we had a care process model that had the practices been more aware and had more education on an ongoing basis, we might not have been in the situation we were when we tried to initiate our program. So our opportunity would have been working with the clinical program earlier for onset of that program. The next challenge that we had was a loss of behavioral health integration. About the time that we were starting our program, a lot of the practices were having some turnover issues where they had had a behavioral health specialist within their practice or in tight coordination with their practice, and they had lost the resource. So that was the second pushback. I don't have someone in my office who can handle this. I don't have the time. We're already full plate with everything we have going in our normal day-to-day. So we worked with our Select Healthcare Management team. We've got a Healthy Beginnings program and a perinatal case management team, who were all 100% willing to step forward and say, let me be a part of the care team. We would love to take care of this for you, but we need you to introduce us as a part of your care team. If not, it's going to be difficult to get these members to talk to us about this sensitive topic. If we're introduced as part of the care team and we're helping with that solution and it's a nice handoff, they're more likely to work with our care managers to help them get connected into care. The other challenge that we had is treatment access varies by product. So especially for our Medicaid population, we've got 3 different geographic areas here in Utah where the access to treatment for our Medicaid is completely different. The intake process, the groups that you would work with, and how many steps in that process were different for each of those 3. So again, with our Select Healthcare Management collaboration, that team said, we'll take care of the entire process. You identify them, we'll help get them into treatment. We'll continue to coordinate so we can let you know how things are going. The 4th challenge was a lack of resource awareness. Many of these practices were not aware of the programs that Select Health offered to support the Healthy Beginnings program. They were unaware of reports that they had access to, and they were also unaware of reference materials. So quickly we put together and started building a repository to help educate our provider community. Next slide. So for some of our other lessons learned, data flow is a must. This is a challenge when we have global billing for our delivery care. When we're trying to help these offices with the screenings and to help them identify performance, it's really sad when all we can give them is a look back. The opportunity is already missed. The time has gone by. And so we've had to work for a number of years to come up with a solution, which Kelly is going to help address in the following slides, so that we could get an awareness of these members ahead of their delivery date, so we could let these offices know if we're missing an opportunity before it's too late. So increase in collaboration for development. I mentioned some of our challenges and opportunities in the last slide, and we worked really closely with our clinical program on the delivery side when we were putting our program together and asking, what do you think about this, that, or the other? We did not have practice participation, and that would have saved us a lot of time in rework. So that would be a lesson learned that I would encourage if you're going to be developing a program. If you have at least one, if not a couple, representative clinics that can help you understand how their workflow is set up maybe differently than other practices you've been working with, what their resources are, and the connections that they're used to having for their members who need services outside of their clinic. Solution for treatment access. I mentioned we identified several different types of access points for our Medicaid members, and then our commercial members would have had a different access route. Lesson learned here is we should have identified those more clearly with a more specific and detailed instruction for the office that would have been easy for them to understand. Of course, the care management team is here to help you, but if you would like to go ahead and connect them yourselves, here's the pathway that you would need to follow for this different membership populations. So a tested workflow and process between the plan and the practice. The care management team working with the clinics, the process is a little clunky at first until we really kind of figure out the best communication mechanisms, timing. Those kinds of pieces would have been really nice if we had tested some of that out with a collaborative practice before we initiated the program. And then the final is dedicated development resource. When our program initiated, we did not have a significant amount of resource that we could spend to develop and evolve the program. The person trying to put this program together was wearing too many hats to really do a great job of kind of checking all of these boxes and getting some of these lessons learned taken care of quicker than we were able to. For here, I say, enter the amazing Kelly, who I'm going to pass the baton to. When Kelly came on board with our teams, this was one of her first assignments, and she had great experience coming into the program, and she had the time allotted in her role so that she could really take us up to the next level. Kelly, would you like to take over?
Thanks, Kim. Yeah, so as Kim said, I joined this team in January of last year and kind of took women's health under my wings. Women's health is very special to me. I'm a labor and delivery nurse in the past, and so it's really important to me that these members are taken care of the way that we really want them to be. So some things that we did starting out was we refocused on the why. Why do we have this program? What are we trying to accomplish? And we came up with, really it's to improve neonatal and women's health outcomes. Next, Kim gave me permission to hire a dedicated team. Before this, we did not have a dedicated team to work on these things. A lot of it is manual chart review, and because nothing is automated with the screenings that we were doing with substance use or depression. And so it really required a dedicated team who would be able to meet with the clinics monthly, give them reports and let them know how they were doing, as well as doing the chart reviews. We also moved from retrospective to prospective reporting. So as Kim said, a lot of what we did was based on global billing. And as you know, that's after a patient delivers. And so it's really hard to then go back and do all the chart review and try to move the needle on these items when somebody's already delivered and gone. It's hard for the clinics to see how they're actually performing and where they need to improve. So we moved to prospective reporting, and the team screens on a regular basis and is able to now report out to the clinics more timely on how they're doing. Audit transparency. So we did provide audits to the clinics. So we took our manual audits, gave them to the clinics so that they could see where the gaps were. Also gave them a chance to say, oh, wait, we missed this on your audit. Can we get credit for it? So that was something that we didn't have before either. And then again, just improving that collaboration between Select Healthcare Management and the clinics, making sure that they were still involved in our meetings, that even providers knew about the care management resources that we had. We were finding that a lot of the providers had no idea. The message was kind of just getting to the managers or those running the program, wasn't getting to the front lines. And so that's been really beneficial as well. And then getting out of the box, looking for ways to improve other health outcomes. So we did add this year a new social determinants of health measure, which we'll get into in a moment, where if the provider codes a Z code, they get credit for that. And so we're really excited about that as well. And then celebrating success. So paying for gaps closed instead of percentages met. In the past, a clinic had to meet, we'll say 70% substance use screenings for all of their members that delivered that year. Now that starting this year, we're actually just paying if you do a substance use screening, you get a payment. So taking that percentages met and just doing it by gaps closed, we're hoping that that really helps to engage clinics who weren't meeting those percentages, that they're actually getting some payment and seeing some benefit from the program. And then we also like to share best practices and provide solutions to clinics who are struggling. And we've had a lot of wins there this year so far. For the program focus for 2023, we are doing depression screenings during and after pregnancy. We're also doing a substance use screening during pregnancy. We've added chlamydia screenings this year, and then that social determinants of health screening. If positive, we're asking providers to code a Z code on that. And then we do ask all of our clinics to do quality improvement projects as well. This year, we're focusing on breastfeeding exclusivity and intimate partner violence screening. We provide training and support for clinics for both the measures and the quality improvement activities, as well as anything else that they might need. And then I just threw this slide in to kind of show our impact. So Select Health is part of Intermountain Health. And so we have 16 Intermountain Health Medical Group sites. We have 6 affiliated sites. Last year, we had just over 3,600 babies that were delivered, which is about 39% of total Utah deliveries. And then just over 7,300 members seen by program providers, and 153 providers are participating in our program at those sites. And thank you for the opportunity to present to you today. We're excited. We would like to open it up to questions if anybody has any. I don't know if people can come off mute, or you can just put them in the chat. Looks like Beth has her. Oh, sorry.
Hi.
Beth, go ahead.
Oh, thank you. It works. I came off mute. Hi, everyone. My name is, I was like, I don't know if I can come off mute. My name is Beth Tinker. I'm from Washington. I work for our state Medicaid agency. So many things were shared that I'm very interested in, but the one that I'll ask that's top of mind, this issue of paying for OB care in a bundled payment where the delivery is the trigger, and therefore, not being able to identify members who are pregnant oftentimes until post-delivery. And I heard you say that you were able to shift to prospective data reporting. And how did you do that? Like, how did you identify? We've looked at like labs or the first try ultrasound, or anyway, that 0500F reporting code, which we don't have a reimbursement for, which I know some states do. I don't know, just what strategy did you use? What worked for you guys in Utah?
Yeah, we have the same issues still happening. And what we've had to do is go to the clinics and say, if you want prospective reporting, we need you to provide us lists of your members every month who are coming in as a new OB patient. We're hoping that we can maybe move the needle in other ways to pull from claims, but that's really how we're doing it right now. And luckily, we have some really good participants in the program who have been willing to do that because they do want that data, right?
I mean, I'll just share in the spirit of, being generous and generative. This is not happening yet in Washington, but I've recently had this idea that I'm going to see if I can make happen to actually pull the initial prenatal visit outside of the bundle, pay for it separately, require, but there's lots of things I like. This is the problem. A certain amount of clinician patient face-to-face time, including IPV screening, comprehensive behavioral health assessment, social determinants of health assessment, as well as the physical exam. Let me sort of get where I'm going here, right? But pay for that actually outside of the bundle. And not only hopefully do we get better care and all those components, but we would also be able to identify pregnant people. I don't know. What do you guys think? I have to get the money for it, but anyway, that's my newest thought in terms of trying to actually solve sort of multiple issues at the same time.
I like that idea. That's interesting. I'd be interested to know if any other plans have tried that. Sounds like you might be the first. We'll be watching for an update. Maybe you'll have the next presentation. Looks like we have another question. Is it Simal?
Yes. Hi. Thank you so much for the great presentation and opening. And I have a question relevant to bundle payment too. So first of all, my hat is a little bit different. I'm a co-founder of a health technology startup working on mental health. Now, the tension that we notice when we talk to providers, they have a bundle payment. So, I don't want to say they don't have any incentive to add more services or proactive services or preventive services, But, you know, in terms of the realities of what they need to do in the end of the day, and then what they get paid for, you know, there's a disconnect. So I'm curious, like, how are you thinking about it moving forward?
For engagement in our program, Kelly mentioned the buy gap closure. So they're not having to wait to get recognized for their program participation until the baby is delivered. While they're seeing that patient through their pregnancy, they complete their screening, they're going to get credit for that gap at that time. We are paying on a quarterly basis, so it isn't every month, but we'll do each quarter. So we're hoping you get a recognition for every bite, and you get paid closer to the time those services are happening. We're hoping that those two things help us to improve the engagement. We're also hoping once they see those coming in, those that have kind of been riding the line with their participation, we're hoping that actually gives them a boost because they're recognizing that they're getting it sooner.
And this is perfect. And one more question related to that. Do you guys are ever considering kind of having a couple tiers of, you know, the total payment bundles based on how the mom is doing at, let's say, postpartum year 1 or year 2, you know, just to give like incentives to make sure that the mental health component is there and well taken care of? Because I'm sure we are all aware that mental health, you know, doesn't change or improve overnight. So we see the effects down the line. That becomes harder in terms of the payment in our healthcare system too.
Yeah, you know, I'm not aware of us considering the tiering for payments after, but I will tell you, so depression screening was the second component that we added into our program, I think about a year before Kelly came. And it was another one of those, we saw in our data, we had 3 completed postpartum suicides, and one's not okay. So that was immediately brought into the program as one of the pieces that we're working on. Initially, we just had the during pregnancy, and then the second year after, we added the post. And we're finding some of the issue is the women who don't make it in for their postpartum check. And so some of the other things that we have considered, not implemented yet, but for the fun of sharing, we've considered, do we try to come up with some kind of a collaboration with the pediatrician? Is there some way that we can bring the pediatrician into the fold to help alert if for the screening with that mom? The challenge is it's not their patient, so we haven't figured out the solution yet, but we're trying to figure out those other access points where the mom might come in if we're going to miss them in that 6-week check. So sorry, Simone, not an exact answer to your question, but that's what I could offer.
No, this is perfect, the start of the conversation. Thank you.
You bet. I'm going to jump to the chat question really quick. Kimberly Price has a question in the chat. How early would we recommend identifying pregnant mothers? Kelly answered, as soon as they hit that first visit. That's the earliest that office typically will know that member, but we take them as soon as we knew, right? Because we're watching for those screenings to happen at different periodicity in the pregnancy. Okay, and then it looks like there's a shared note. Thank you, Kimberly, for the positive pregnancy test claim coming in. I think we have another hand. Alana?
Yeah, you kind of touched on it with your comments on capturing the caregiver through the pediatric home. It was mentioned yesterday, you know, we have trouble getting the postnatal, the postpartum visit in, but 98% will make their kids' appointments, and we can do and are doing screenings there. I come from a children's hospital setting, and we can do the screenings, and we are doing the screenings, but we can't then serve without access to things like Z codes, and it's oftentimes the insurance barrier. So I'm wondering, you know, where else can we take this conversation? Where are those pathways? And what else can we open to make it an accessible point? And it shouldn't just be about a warm handoff to somebody else still, because we know that there's a lack of providers across the board. So even just thinking that, yeah, if I can screen them and we can find them a home, we can't necessarily, but I have providers, I have social workers, I have care coordinators within our children's system that can address it from a dyadic perspective if we can sustain those programs. And I can't sustain those programs without getting paid for them. So kind of wondering where you guys are in those thought processes to kind of like enter a new setting, or however we need to look at it. Because originally I was going to ask more, like, looks like you've got your OBs on, but where are your pediatricians in that whole setting too? Because they are touching so many of those caregivers.
You're right. So just to kind of step back one half a step here. So for the programs that we have for pay for performance at Select Health, Kelly is actually managing 4. We have a behavioral health program and a nephrology or kidney health program that just rolled out this year. So we're in almost end of month 3. And then we've got a primary care, which includes pediatricians and the women's health that we're sharing today. So I don't have great solutions. What I would say is, working as closely as you can with your plans. We're really interested in talking with our provider network and having them help us understand their barriers. Kelly's team will host what we call a best practice meeting once a year, where we invite the practice, whoever you want to send, come to this meeting. And it's a place for us to have clinics share with clinics and for the clinics to share with us the kinds of things we can be looking at or working on. Because we just invite the clinic and whoever can come, we get a pretty wide range of participants, from front desk to nurse to provider, receptionist, so we get a kind of cross section of flavor there. So in order to change benefits for plan, you got to lobby on the Hill to get a change overall, or you got to work with the close partners that you have for plans to see if we can come up with solutions together. So I'm sorry, that's probably not exactly the answer you were looking for.
No, it's all good. And I see Heather also responded. I mean, for those that are in systems where they have both the pediatric and obstetric, like within the same healthcare systems, that can work. But oftentimes it's not. And so we're looking at other solutions.
Yeah, for us, it's a challenge too. We're part of an integrated system, but when you look at our full provider network and the practices that are participating, we have more of our affiliated contracted providers than we do the ones we have direct connection with. So we're always trying to work on both solutions. How can we work better with the folks that we have in our family, and how do we work better with those that are highly aligned and contracted? And oftentimes it's not the same solution. We've got to oftentimes come up with a different solution depending on the group.
Yeah, and we always do give the resource of care management through Select Health if needed, but a lot of these groups do have their own care managers as well. But just to say, we have resource, refer people to us, and then they can take that on and provide them those resources too. So I do like the idea of adding it to the new baby screenings or the well child checks as well. So I think I might take that and maybe look into that for next year.
The other thing that I just want to put a plug in that Kelly has done, we've always had this care management team that's been willing to jump in, willing to help. Let me make sure you have the contact information. Kelly's taken it to the next level, and she actually has the care management team go out and meet with the clinics with her. Her team has regular meetings. I think many of them are monthly. Some might be every month or quarterly, but I think most are monthly. That care management team now is just seen as part of the program. When members enroll into the Healthy Beginnings program with that Healthy Beginnings team, they're also doing screenings. So we're hoping that may help catch some of those moms who maybe don't go to that 6 month, but they want to get their incentive for participating in our Healthy Beginnings program. And that's the final step in order to get that payment. So that's, there's never one solution. We've got to try lots of little things to see if we can get to the big numbers. So that's another thing that we've worked. Kelly has done a really great job getting more close connection and involvement with that team.
I see a question from Sarah. So Joy asks, are you doing anything to pay OBGYNs outside of the 6-week appointment to align with the ACOG's postpartum care guidelines, even on a fee-for-service basis? So part of our program, we are doing the postpartum depression screening up to 12 weeks to align with ACOG. As far as the fee for service portion of it, I don't know, Kim, if you know if that's outside of the global bill.
I am not 100% sure.
Hopefully that answered that question. Okay, there's another. I'm not sure if your states will allow a pediatrician to bill on a baby to do a depression screening on mom or dad. In Indiana, providers can bill 96161, but a lot of feedback has been that they don't know what to do with a positive screening. So yeah, back to that same thing, you know, what do we do? What do we do when somebody screens positive for X, Y, and Z? You know, just making sure that they have those resources. And hopefully every state has some type of a resource. We do refer to 211 a lot and to our care management. Okay, let's see. In Washington State, Medicaid pays for parent caregiver depression screening for the first 12 months of life for the infant. I don't think there is coordination to the birth parent's provider though. Yeah, that's awesome.
That is awesome.
But having that coordination back definitely is something that is a barrier if a provider doesn't know.
Yeah, I think those coordination efforts and the trying to connect with case management, I think the difference for us, for the level that we have been able to get to, and I love that you guys are sharing so many ideas because you guys have thought of things we haven't. So thank you, appreciate that. I think Kelly's team really makes a difference, right? We've gone ahead and taken the expense for this team that can work so closely on clinical pieces with the offices. Our provider relations team is what we call them. I think it's a pretty typical, your group that works with offices on their general contracting and fee schedule and those kinds of pieces are typically non-clinical. These conversations are too difficult for that team. So I think us setting up this clinical team, Kelly's team is made up of half nurses and half project managers. So we've got the operations pieces for the program, but we also have a clinical person working with each one of these practices. I think that's made a huge difference for us, getting engagement from the practice, getting kind of validates program a bit. And I think it helps when that team then is working across all of these other departments trying to make these connections. So I love the idea of these. You guys have given great ideas and I love the share of the 96161 code. Thank you for that. I think that's a great opportunity that we could look into and take advantage of Kelly's team to try to help make those connections back to primary care, since many of those are going to be participating in her other program. So thank you.
Yes, thank you. And then I see a question. Do you feel like there's such a thing of identifying too early, say through ED visits for a different issue? So we don't typically identify through ED visits or even positive pregnancy tests because we don't know where that patient is going to end up. If they're going to be as with a provider that's part of my program or a different provider, it's just really hard. I think that the Healthy Beginnings team, when they're identifying high risk patients, members, they might use some of those kinds of codes. But again, the next question about the sensitivity, if they have a missed abortion or termination, if they have an early positive pregnancy test, and then we do outreach to them through Healthy Beginnings, that can be kind of troublesome. So we really try to wait a little bit from the Healthy Beginning side, from my understanding, until they know for sure that it's a viable pregnancy or the member wants to keep that pregnancy. So hopefully those answered both of those questions.
Yeah, so Kelly, Angela added a note under there too, and I agree. We can also use that as an opportunity to offer support, resources, and connection.
Absolutely.
If that be the case.
Yeah, and I don't know if the Healthy Beginnings team does that. We don't do direct member or patient outreach. That's usually through Healthy Beginnings. So that's a good thought too. If they identify a lost to maybe have somebody outreach to them. I hear somebody maybe trying to talk.
Hear me?
Oh, now we can.
You can hear me?
Yes.
Okay. I just was wondering if I could just take a second and just explain my reasoning behind my questions.
You bet.
Okay. So as a maternity care coordinator, we were identifying members typically through their first prenatal visit. This was a pregnancy that they had planned on keeping. It was a viable pregnancy, and we would follow them through delivery. Well, then things changed. So what's happening is, I'm trying to figure out a workaround with it, is we're identifying members really, really early, like through ED visits where they're 4 weeks pregnant, or they just found out they were pregnant and they're going to terminate, or it was a missed abortion. Well, then there's like all these other issues that come with them, substance use, behavioral health, maybe social situations where a different pod of specialists in behavioral health or substance use would be able to assist the member, but just because of that positive pregnancy test, they come to us. So we get tangled up, I say, in the briar patch. But I feel like, I guess my concern is, I've noticed it's taking away from the maternity members that have perinatal mood disorders and have needs specific to maternity. Like a lot of, I guess what I'm trying to say is, a lot of members are being identified as maternity when there are other greater issues that somebody in a more specialized area would be able to assist them with. So I'm trying to figure out like the best way to, like, I guess, present this to my leadership, and maybe go back to what we were doing or figure out a different way.
Yeah, that is tough. That is a tricky place for your team to be in. For us, for the way our teams are set up, we've got multiple care management teams, and there are some that are by specific product just because the regulatory is so strict, and we need to be so mindful of that. And then we have some that are more based on specialty. That group is all under one umbrella, and so they have their own kind of handoffs. That's how we would handle it at our plan. Those teams would work together to decide who best to follow that member. And we do have some that, because they're so complex, you might have 2 different care managers working with that member to help make sure that we're covering all of the need. So I'm not sure if that helps you in the way that your plan is set up, but that's how we would handle it at ours.
It definitely makes sense, and thank you for sharing.
You bet. Good luck, Kimberly. That's a tough place to be.
Yeah.
I feel you.
I think some of the prenatal care questions can go to ACHP too. I was part of the planning with ACHP for the items that they shared. And that was one thing that we said over and over, with the global bill, how do we identify? And then if we do identify, is it too early? And so I would love to hear what Megan or Nissa have to say about where they're thinking health plans can go for that.
That's a great question. I wish I had my my materials in front of me, because one of the resources that we had developed as part of our work on the Raising the Bar grant was a summary of some interviews with ACHP plans that who had shared both the barriers to early identification of pregnancy and also some possible solutions. So if people have other questions, I can, if you give me a second to pull that up, I can share some tidbits from that.
But as Megan mentioned, a lot of the questions that we received today are pretty consistent with the struggles that other plans had in those interviews. So it's heartening to see that the conversation is still current, but we're definitely exploring options to triage that.
Sorry to put you on the spot, Megan.
No worries, no worries. Let's see here. Yeah, because I remember we got some really great intel from plans. Let's see here. Let's see, recommendations. Okay, let's see. So so these are some things that ACHP member companies have done to better to do a better job of identifying patients earlier in pregnancy. So for Medicaid enrollees, some health plans use the health risk assessment, which asks whether someone is pregnant, what their due date is, and if they have conditions that would put them at risk of an increased risk of poor outcomes. Let's see. Health plans send this health risk assessment annually to people with Medicaid coverage and to new Medicaid enrollees upon enrollment. And then some Medicaid programs provide health plans with a weekly list of enrollees whose claims identify them as possibly pregnant. Health plans then reach out to the maternity care provider who submitted the claim to ask for verification of the pregnancy and the estimated due date. Providers obviously are a critical source of early identification, and they can provide health plans with individuals' pregnancy and health history and identify people who could benefit from health plans' high-risk pregnancy case management programs. So providers ideally notify the plan of pregnancy after the first prenatal visit by submitting the claim in a timely manner. Plans also review prenatal claims on a monthly basis, and providers also have information about health plans, resources, and services in their offices, and they can refer patients directly. Let's see, health plans have pregnancy notification programs with their contracted clinic systems, and emergency room and hospital notification systems alert health plans when a member is in the emergency room or is admitted for a pregnancy-related condition. Health plans are using vendors such as Ovia Health to provide people with comprehensive support leading up to pregnancy, during pregnancy, and postpartum. And one feature is a user-friendly self-report of pregnancy. If you're an integrated care system using electronic medical record data, using, like we mentioned before, laboratory data from positive pregnancy tests, ultrasound data, and claims for prenatal vitamins, although that one can be tricky because people can use prenatal vitamins for other reasons. And then local WIC offices have established partnerships with health plans and submit a monthly report to the plans of all the pregnant participants who have given consent. Pregnant people often seek assistance from WIC even before seeking prenatal care. So those are some of the things that we've learned from ACHP member companies.
Megan, you do have a question in the chat. It says, I apologize. Missed the mention of the name if there was one of the screening tool.
Oh yeah, let's see.
Oh, Nisa, you're too fast. Nisa
sorry.
answered.
I'm assuming this is referring to the maternal health measure set tool that the question is about. I apologize if that's not the case, but we are, I believe, Megan, the tool has been released publicly now, right? The measure set?
Oh, yes, if that's what you're referring to, what we presented on, yes, that is available as part of the materials for raising the bar. But if you're referring to some of the information that I just shared,
It is. She was referring to the measure set.
oh, okay, the
Or
measure
they
set,
were
okay,
referring to-
perfect.
yeah.
Yeah, so that can be located at nationalpartnership.org / raising the bar, I think. But if you just Google National Partnership of Women and Families for women and families and raising the bar, it will appear as part of the, I think it's called like the toolbox, that you can download a PDF there.
Megan, I think the question also is if you have any instruments from the information that you just shared from plans.
Yeah, let's see here. Let's see, you mentioned a screener, so let's see here. I think, was it maybe the health risk assessment for Medicaid enrollees? Could that have been it? For Medicaid enrollees, health plans use the health risk assessment, which asks whether someone's pregnant, what their due date is, and if they have conditions that would put them at increased risk of poor outcomes.
Okay. Was that shared as just the state's health risk assessment, or was there a standardized tool they were using? Do you know, Megan?
I don't know. Yeah, it's been a while since I've looked at these documents.
It
So
might
I'm
have been the state-based one, Megan, if there were, because our plans are across all different states, so just, it might be safe to say that it was individual state-based ones.
That's great. Sarah, thank you so much. Sarah is also helping us out in the chat. She has listed a link for some screening tools that are available. Thank you, Sarah.
Also, I was just looking through that list that Sarah shared for the social determinants of health. We don't have a preferred screening tool that our clinics use, but we do like the social check. So if that's something that plans are looking at in the future, or clinics, whoever is looking at, that's a good one. Used to be Prepare, I think now it's the social check.
Any other questions from the group?
Hi again. So I have a question about the, couple of the measurements that were mentioned about screening and then following up in 3 months, or in, I think, substance use, it was 2 months. I mean, following in 1 month and then, or 2 months. I mean, I'm not sure if you have the actual measurements, but my guess is we are definitely not there. So how do we plan to achieve it? And more specifically, what do you mean by the follow-up care? Would that be, just a call from the discharge nurse, or would that really include like mental health assessment by a licensed professional? The start of the therapy, the start of the pharmaceutical treatment, what are we really meaning by that measurements?
Alana, can you help me? Is that a question for Select Health for the program, or is that a question for ACHP for the standardized measurement list?
It was mostly for ACHP, but in general, like, whoever has any inputs on the meeting today, I'm happy to hear too as well.
Yeah, I think it would be interesting to hear specifically how Select Health is implementing that measure. I think that that for us, we saw the unhealthy alcohol use measure and thought that that it was that a measure that encompassed more than just unhealthy alcohol use would be more comprehensive. And so that's, but again, this is just a measure concept. We're not measure developers. So, so the specifics, I think, are kind of left to the, you know, if someone wants to take that concept and develop it, I think we would be happy to collaborate. And then also, I think if plans have a specific idea of what that would look like, then they can kind of take that and run with it as well. But it looks like the Select Health team has come off of mute.
For our program, so clinics that participate in our program, we do provide them resources, again, through care management, or some of our clinics do have mental health integration still, and so they're able to follow up pretty closely within that time frame. I would say the hard part is when you have members who are outside of the program, or clinicians who are outside of the program, knowing how they're addressing these issues. First of all, are they doing the screenings? And then secondly, how are they doing follow-up if they are? So that is a barrier that we still have outside of our program, I think. So, you know, these are measures that are, I believe, going live. The PDS, I want to say it's PDSE, and I don't remember the acronyms through HEDIS, but I believe they are going live and they are going to require follow-up. So I would love to hear what Megan just said, you know, how health plans are planning to do that follow-up after this positive screenings.
You know, not specific to this measure, but for some others, non-OB related that we have follow-up like this, a lot of those right now are still hybrid. And so they're evaluated because we do chart review at the end of the year. But HEDIS is moving away from those hybrid measures. It's going to take, you know, some years to get there. So we're going to have to come up with a solution for this. We're going to have to make sure that we've got some coding or some other mechanism. You know, one of the other problems that we have with a lot of the HEDIS measures that are going to electronic only is there are pieces of it there are pieces of information that make that numerator hit that don't come in on a claim. So claims aren't the only answer to get us to solution for these measures either. We're trying to work on data feeds with our participating practices so that we can have both the clinical and the claim to close that loop. And if we've got coded fields for some of these follow-up pieces, that might be a solution. Do we have any other questions from the group? Oh, thank you, Sarah. Please, folks, notice in the chat, Sarah's added some additional information for the HEDIS follow-up measurement. There's some links in the chat. All right, I don't hear anyone else coming off of mute, and I don't see any other questions in the chat. If we don't have any other questions, we can give you a couple more minute break before your next session. So I'll just make one last call and then we'll wish you an amazing rest of your day. Okay.
Thank you, everyone.
Thank you.
We're at the end. Thank you so much, everyone.